Anticoagulants are some of the most difficult drugs to grasp, but they're used so commonly that we need to make sure that we understand what's going on. If you haven't watched the coagulation PowerPoint, I strongly urge you to do so now, because even if it doesn't make a whole ton of sense, it's going to help you sort through these different drugs. Now, the primary purpose of the coagulation cascade is to form a clot through the formation of fibrin. If you are wanting to stop coagulation with an anticoagulant, you need to decrease the formation in fibrin in one way or another. The uses for all of these drugs are going to basically be the same. Now, you're going to have some drugs that you prefer one way or another, but they're going to be used for pulmonary embolisms, DVTs, strokes, TIAs, myocardial infarctions, prosthetic heart valves, atrial fibrillation, and prior to surgery or after surgery in order to decrease the risk of clot formation. So just remember that the uses are virtually all the same. It's the side effects and the interactions that are going to help us choose the drugs. Now, in our first category, we're going to talk about vitamin K antagonists, but I want you to know that the same black box warning applies for everything. That is, a patient with a recent epidural or spinal puncture is not going to be on an anticoagulant because it's going to allow for hematoma formation and paralysis may occur. For all of these drugs, we don't want to use too many drugs that decrease clot formation all at the same time, because it'll increase the amount of bleeding in that person. They may start bleeding out in their urine, in their GI tract, in the feces, even just cuts on their hands, or if they're in a traumatic accident. We want to be able to control the bleeding in these patients. So it's a perfect balance between too much bleeding and not enough. Starting with our first category, it's going to be the vitamin K antagonists. And I want you to repeat once again in your head: 7, 9, 10 prothrombin. These are the specific factors that have to do with vitamin K, and they're inhibited by inhibiting the vitamin K conversion into its active form. Once again, ignore the uses. They're all going to be virtually the same. But the side effects are increased bleeding and fatal hemorrhages, as well as weakened bones in the long term. For warfarin, there are so many interactions. The reason is because it's not only metabolized by a CYP enzyme, but it's 99% bound to albumin. So any drug that is also bound to albumin is going to cause warfarin to be displaced. It's not going to be able to metabolize the way that we expect it to, and they're going to have a higher bleeding time than what we therapeutically want. As a result, these individuals need to be monitored very closely with their PT and INR, which is through that extrinsic pathway, in order to make sure that they are at a target limit. Now, the contraindications for these patients: anybody with uncontrollable bleeding, high risk for bleeding, liver disease, and a vitamin K deficiency. They need to keep their dietary vitamin K constant, and because it's a vitamin K antagonist, we can reverse it with administration of vitamin K, but know that that will actually take a few days. So what you need to do is administer immediate platelets and then allow for a reversal with vitamin K in the long term. Next are drugs that activate antithrombin. This is mainly low molecular weight heparin and heparin that's unfractionated, but it also includes another drug we'll talk about in a moment. Now, the low molecular weight heparins are going to preferentially inactivate factor 10A. Unfractionated heparin has effects on quite a few different factors. Once again, the uses are basically the same: MI, strokes, even DIC, but heparin that's unfractionated is preferred in pregnancy. Bleeding is the major side effect, but heparin-induced thrombocytopenia can occur. As a result, we don't want to use this in individuals with pre-existing thrombocytopenia or uncontrolled bleeding. This can be reversed with protamine sulfate, and it's given subcutaneously. Additionally, unfractionated heparin can be given IV. and it must be monitored by a prothrombin time and adjusted to our specific goals. The other drug that activates antithrombin is listed right here. I'm not even going to try and say it, but it does have, once again, that selective inhibition on factor 10A. Uses are the same, but watch out for that severe renal impairment. It's not effective in these patients. However, the bioavailability is very good at 100%. For direct thrombin inhibitors, we're going to inhibit the thrombin, which allows fibrinogen to convert to fibrin. As a result, if there's no fibrin, there's no clot formation of that polymer. The uses are virtually the same. There's either deserudin or dabigatran that you'll see most commonly. Side effects are bleeding, and watch out for that renal impairment. Now, dabigatran is reversible, but it's also a prodrug. So food is going to delay the rate of conversion, but not the extent. For direct factor 10A inhibitors, these are your oxybans. These are the new oral anticoagulants. This is rivaroxaban, apixaban, edoxaban, and they're going to bind factor 10A, which stops thrombin and fibrin from forming. Uses are the same, bleeding is the same, but this is a P-glycoprotein and CYP drugs, so they may interact with several other drugs. Watch out for that renal and hepatic impairment and the high risk of bleeding, as we've had to look out for in every other anticoagulant. Now, I want you to know that these are now reversible with a monoclonal antibody. However, there are a lot of places that do not carry it because it's a more new age drug. It's a more new age reversal agent. And so you can use prothrombin complex, which actually has 4 different factors in it to allow for coagulation to happen. I want you to think about reversal mainly in times of traumas, presenting to the ER from a car accident, and you have to reverse the amount of anticoagulation that has occurred.